Welcome to the deep dive. So our mission today is, well, it's to unpack a highly specific, complex, and honestly deeply impactful medical journey.
It really is.
Yeah, we're going to explore how a history of recurrent marsupialization surgery, which is used for Bartholin gland, obsesses how that can unintentionally alter the local vulval architecture and, trigger chronic severe entrance pain.
Right. The condition we are looking at is secondary provoked vestibulodynia. And it's basically a masterclass in how a mechanical solution can cascade into a massive neurological loop.
Exactly. And just to set the stage for you listening, we've got a pretty dense stack of medical literature forming the foundation for this. We are pulling from the 2014 UK National Guidelines on the Management of Vulval Conditions, clinical reviews from the European Archives of Medical Research, and some advanced texts on pelvic surgery.
Yeah, and we're heavily relying on a really comprehensive 20-year retrospective study by Dr. Richard Assorti. That one was published in Pelvic and it focuses on refractory vulvodynia.
Right. So if you're going into this thinking about a standard surgical fix, you kind of have to shift your perspective. Like think of a pressure relief valve in a high-friction, high-heat engine.
That's a good way to picture it.
Yeah. So if that valve gets clogged, the pressure builds up to catastrophic levels. You obviously need to clear the valve. But imagine if the act of cutting into that valve to clear it somehow rewired the engine's entire electrical diagnostic system.
So the dashboard alarms are just permanently blaring every time the engine merely idles?
Exactly. You wouldn't expect a mechanical clearance to trigger an electrical meltdown.
No, you wouldn't. And that is the exact paradox we're dissecting today. We like to view surgical interventions as, precise, isolated events, like they have linear outcomes.
You drain an abscess, the tissue heals, and boom, the problem is solved.
Right. But what Dr. Reed's data and the broader literature reveal is a story about the body's healing process going fundamentally systemically wrong. It's really about a localized structural intervention triggering this devastating neurological and muscular cascade.
And the epicenter of this entire cascade is the Bartholin gland.
Right.
For those who might not know the exact anatomy, these are the greater vestibular glands sitting at the 4 o'clock and 8 o'clock positions of the vaginal opening. And their function is pretty straightforward, right? They secrete mucus for lubrication.
Yeah, they do. The fluid travels down a 2 to 2.5 centimeter duct to the surface, but when that duct gets blocked, whether that's from localized friction or maybe a bacterial shift involving E. coli or other pathogens, that fluid just backs up into a cyst.
Right, like a blocked pipe.
Yeah.
But I want to ask on behalf of everyone listening, since small cysts are often completely asymptomatic, what makes the jump to a painful abscess so drastic? Like, why does it get so bad so fast?
Well, the clinical crisis only really initiates when that stagnant trapped fluid becomes infected. And the transition from a quiet cyst to an acute abscess, it is violent at the cellular level.
Wow, violent.
Oh, yeah. You have this massive influx of polymorphonuclear leukocytes immune cells. And the area experiences rapid, localized cellulitis, intense swelling, and severe pressure necrosis.
That sounds incredibly painful.
It is. Because of the anatomical location, the sheer mechanical pressure of an abscess makes basic mobility, like just walking, sitting, shifting your weight, completely excruciating.
So it's an acute physiological distress signal. The pain is so severe, and the recurrence rate of these abscesses is actually really high, which means clinicians need a permanent drainage solution.
Exactly, because simply lancing and draining it just isn't enough. The duct will literally just seal right back over.
Which brings us to the most common surgical intervention for these recurrent cases, marsupialization.
Yes. And the operative logic behind marsupialization, it makes perfect sense structurally. The surgeon makes an elliptical incision over the abscess, and they completely evacuate all that purulent fluid.
Okay, so they drain it out.
Right. Then they avert the cyst walls, so they fold the inner lining of the cyst outward, and they suture it directly to the adjacent vaginal mucosa and the vestibular skin.
So they are essentially creating a permanent pouch, like a kangaroo pouch, which is actually where the term marsupialization comes from.
Spot on, yeah. The objective is to force the cavity to heal by secondary intention, basically healing from the bottom up while leaving a newly constructed, permanently open tract so the gland can just continuously drain.
On paper, that sounds like a brilliant mechanical bypass. You just remove the roof of the obstruction.
Yeah.
But here is the catch.
There's always a catch.
Right. The pathology emerges when this procedure is performed recurrently. The sources are very clear that the specific tissue of the vestibule is just not designed to endure repeated incisions and suturing.
Not at all. Dr. Reed's 20-year retrospective really highlights this. It shows that recurrent marsupialization actively, permanently changes the physical landscape of the vestibule. We start seeing severe, unintended architectural alteration.
So let's trace that physical alteration. Because every time you perform a marsupialization, you inevitably create a semicircular peri-orificial scar around that new opening.
Yes, and Dr. Reed meticulously tracked the life cycle of this specific scar tissue. In the initial postoperative weeks, the tissue forms what's called an elastic red scar. It is highly vascularized, it's rich in fibroblasts, and crucially, it still has compliance. It can stretch.
Okay, so that elastic phase, that is the defining window for intervention, right?
It absolutely is. Dr. Reed's protocol dictates that starting in the 4th postoperative week, the patient must use a glass vaginal dilator, specifically a size number 4 or 5.
And why glass specifically?
Well, it's about the firm, consistent mechanical tension. The tension applied by the dilator forces the maturing collagen fibers to align in a way that actually preserves elasticity.
But if they don't do that?
If that mechanical stretching is absent during this really specific metabolic window, the scar rapidly transitions into an inelastic white scar.
And once that collagen cross-linking solidifies into an inelastic white scar, the tissue dynamics are permanently altered. At that stage, any physiological attempt to stretch the tissue doesn't yield flexibility anymore. It just causes micro-tearing and cicatrization.
Yeah, severe scarring. And Dr. Reed's statistics are actually pretty sobering here. He notes that at least half of the women who delay or skip that precise postoperative dilator protocol develop severe scar dyspareunia, which is incredibly painful intercourse.
Wow, half. And the localized scar is just the epicenter, right? The recurrent surgical trauma induces architectural shifts across the broader vestibular environment, too.
Oh, totally. The literature documents rampant hymenal fibrosis, so thickening of the hymen-dense contracture bands forming on the posterior fourchette, which is the back edge of the opening, and profound stenosis or narrowing of the glandular ducts themselves.
If we look at the mechanics of this, I mean, it's kind of like tailoring a piece of highly specialized load-bearing fabric.
I like that analogy.
Yeah, like if you repeatedly cut a fabric that is biologically required to stretch, and then you stitch in rigid, non-stretch seams of dense collagen, the entire mechanical function just fails. Every time the tissue is subjected to tension, it binds, it pulls, and it shears.
Exactly. The recurrent surgeries are effectively installing rigid barricades in an area defined by its need to be compliant.
Right. But the structural tightness is daunting enough. Yet the mechanical failure is only the first phase.
Sadly, yes.
The recurrent surgical trauma actually triggers a cellular response that radically alters the local peripheral nervous system. The physical shape changes, but more alarmingly, the electrical wiring of the tissue goes into a state of hyperproliferation.
And this brings us to allodynia. Patients develop a localized pain response where a completely innocuous stimulus, like just the light touch of a Q-tip during a clinical exam, triggers this searing, burning pain response.
The Q-tip test. It's wild that the nervous system is suddenly interpreting light pressure as catastrophic tissue damage.
It is, and the pathophysiology behind this allodynia is completely driven by the biology of chronic inflammation. See, when the vestibule is subjected to recurrent surgical trauma and the chronic inflammation from the abscesses, local mast cells basically flood the extracellular matrix.
And mast cells are the primary orchestrators of our immune response, right?
Right. And in this specific hyperinflamed environment, they begin to excessively synthesize and just dump a specific protein called nerve growth factor, or NGF.
The data on nerve growth factor in these cases is staggering. The excessive NGF physically fertilizes the local pain nerve endings, the C afferent nociceptors.
Yes.
And we aren't just talking about existing nerves becoming a bit more sensitive. The research demonstrates up to a 10-fold increase in the actual physical density of these pain nerves in the superficial vestibular tissue.
It's incredible. The nerve fibers literally physically branch and sprout, densely populating the epithelium. The surgical site just becomes this hyper-dense minefield of nociceptors.
Okay, I have to push back on the biological logic here, though.
Sure, go ahead.
We know inflammation is meant to coordinate healing. Why on earth does the body's natural response to surgical trauma involve multiplying pain receptors by a factor of 10? I mean, that isn't healing. That is active biological sabotage. What is the evolutionary utility of permanently hypersensitizing a completely healed wound?
Right, it seems entirely maladaptive, at least until you look at the genetic variables involved.
Genetics.
Yeah. The consensus in the literature is that this extreme nerve proliferation doesn't happen to every single patient who undergoes recurrent marsupialization. A specific subset of women possess genetic polymorphisms that essentially disrupt the inflammatory off switch.
The off switch.
Yeah, so normally, once the surgical site is closed and sterile, enzymatic pathways signal the mast cells and macrophages to downregulate, to basically pack up and go home.
So the genetic variation prevents that downregulation.
Precisely. The enzymes that clear the inflammatory cytokines are sluggish or they're just defective. So the local tissue environment remains absolutely saturated in an inflammatory broth. The body perceives a constant, unyielding state of injury.
Wow.
Yeah, so the excessive sprouting of those C. afferent nociceptors is really a desperate, misguided protective mechanism. The body is building this massive hypersensitive security system because it genetically cannot recognize that the acute threat has actually passed. And this is the hallmark of secondary provoked vestibulodynia. It is acquired strictly after the surgical trauma.
The compounding effects here are just brutal. You have a vestibule that is physically bound by rigid, inelastic white scar tissue from the recurrent marsupializations.
Right.
And that exact same tissue is now wired with 10 times the normal density of pain receptors. But the pathology doesn't even end at the superficial skin, does it?
No, it doesn't.
This massive influx of sensory data crashes into the central nervous system, and it creates a self-sustaining reflex loop.
And this is the transition into complex regional pain syndrome, or CRPS. It evolves into a deeply entrenched three-part spinal reflex arc.
3 parts.
Yep. The cycle initiates with the nociceptive element. Mechanical contact with that hypersensitized, scarred vestibular tissue fires off a massive volley of action potentials.
Okay, so a touch happens, and those amplified pain signals travel at the afferent sensory nerves directly into the central dorsal horn of the spinal cord. The dorsal horn is suddenly just bombarded by this tenfold nociceptive screaming.
Exactly. Screaming is the right word for it. The dorsal horn is overwhelmed and it becomes centrally sensitized. And in response to this sensory bombardment, the spinal cord fires back.
A reflex.
Right, but it doesn't just send sensory feedback. It fires a relentless motor signal down the efferent arm of the reflex arc. This descending motor signal targets the levator ani muscles of the pelvic floor, and it drives them into a state of chronic, involuntary, and really painful spasm.
Which is clinical vaginismus.
Yes.
And that muscle spasm introduces the final locking mechanism of the loop, the myalgic element. Because when the levator muscles are locked in a chronic state of hypertonicity, when they're clenched, they compress their own vascular supply.
They cut off their own blood flow.
Exactly. This severe restriction of blood flow leads to localized ischemia. The muscle tissue is literally starved of oxygen, forcing it into anaerobic metabolism. And that rapidly builds up lactic acid.
So the chemical environment of the muscle becomes highly acidic.
Right. Anyone who has hit muscle failure during an intense workout knows that burning pain of lactic acid. Now imagine that deep ischemic ache locked continuously into the entire pelvic floor.
Oh, it sounds unbearable.
It is. The lactic acid directly stimulates the muscle nociceptors, creating this deep, visceral aching pain that sits directly underneath the sharp, burning neuropathic pain of the skin.
It is quite literally a closed-loop system of perpetual agony. The neuropathic pain triggers the motor spasm. The motor spasm causes ischemic lactic acid buildup, and then the spastic muscles pull sharply against the rigid, unyielding scar tissue from those marsupializations.
Which mechanically fires the proliferated surface nerves all over again.
Exactly. You cannot successfully treat this by focusing on just the skin or just the muscle. The intervention has to disrupt the entire arc.
So let's examine the protocols for actually breaking that loop. The clinical guidelines prioritize conservative therapy first. And looking at Dr. Reed's data, an impressive 85% of patients can actually break this CRPS loop using a dual conservative approach.
Yes. The conservative protocol attacks the central and motor components of the reflex arc simultaneously. Pharmacologically, they utilize membrane-stabilizing drugs, typically gabapentinoids or tricyclic antidepressants.
Okay, so drugs that calm the nerves.
Right. These agents work centrally to dampen the hyperexcitability of the central dorsal horn. They restrict the calcium channels, which essentially raises the threshold required for the nerves to fire in the first place.
So they basically turn down the volume of the pain transmission.
Exactly. And alongside the pharmacology, they use biofeedback-controlled physical therapy. They place surface EMG electrodes on the hypertonic pelvic floor muscles.
The spasming ones.
Right. The electrical activity of the spasm is actually displayed on a monitor in real time. So the patient can visualize their own internal spasticity, and they use that visual feedback to consciously, neurologically override the efferent motor signal. They literally learn to actively draw and relax those levator muscles.
Okay, wait. I have to challenge this 85% success rate for a second.
All right, go for it.
We just established that the recurrent surgical trauma physically grew 10 times the normal amount of pain nerves in the tissue. The architecture is physically altered. If the hardware itself has proliferated to that degree, how can membrane stabilizers and biofeedback fix 85% of cases? You can't just meditate away a 10-fold increase in nerve density.
That is a highly valid biological question.
Yeah.
And you're completely correct that conservative therapy does not magically erase the proliferated C-afferent nociceptors.
Right.
The extra hardware is still there. However, the goal of conservative therapy isn't to remove the nerves. It is to desensitize the central nervous system's reaction to them. By using membrane stabilizers to forcefully block the dorsal horn from reacting and using biofeedback to stop the muscle from constantly pulling against the scar, you break that self-feeding feedback loop.
Ah, I see.
Yeah, when the spinal cord stops receiving the compounded signals of both the skin touch and the muscle ischemia at the same time, the central sensitization gradually downregulates. The body essentially learns to ignore the extra hardware.
Okay, so the extra nerves are still there, but the central alarm system has been successfully reprogrammed to just mute them. That does make sense.
Yeah.
But that still leaves the refractory 15%.
It does.
For those patients, the localized scar tissue from the marsupializations and the hyperproliferation of nerves deeply embedded in that tissue, it generates an acceptive signal so violently intense that no amount of medication or biofeedback can lower the volume.
Yeah, and for that highly refractory subset, surgery is the absolute last resort to break the cycle. You have to physically excise the hyperalgesic tissue that is driving the reflex arc.
And the surgical debate centers on how aggressively to intervene, right?
Yeah.
The two primary methodologies are traditional vestibulectomy versus targeted microsurgical excision.
Correct.
The traditional vestibulectomy is, well, it's a major anatomical alteration. The surgeon essentially removes the entire sensitive skin of the vulvar vestibule. And to reconstruct the area, they perform a vaginal advancement flap.
Which means?
They undermine the lining of the vagina, pull it down, and suture it to the external perineal skin.
Right. And it carries significant morbidity and alters the structural dynamics of the vaginal canal entirely. This is why Dr. Reed's 20-year data heavily advocates for a highly targeted alternative.
The microsurgical removal.
Yes. Microsurgical removal of the Bartholin gland itself, rather than stripping the entire vestibule.
And the core argument Dr. Reed makes here is really about the origin of the pain signal. He asserts that in these severe recurrent marsupialization cases, the most potent nociceptive firing isn't just coming from the superficial vestibular skin. The primary pain generator is deeply embedded within the chronically inflamed, scarred remnants of the hyperalgesic Bartholin gland itself.
Exactly. If the gland is the primary noxious trigger, a superficial vestibulectomy might completely fail to capture the deepest source of the pathology.
Which is terrifying to think about, undergoing all that surgery and missing the source.
Absolutely. Dr. Reed's technique utilizes a CO2 laser for microscopic dissection. It prioritizes extreme precision and hemostasis. The critical maneuver in his approach is what's called tension counter-tension.
Right, so the surgeon utilizes fine skin hooks to apply traction to the incision margins. This wide exposure is super vital to access the Bartholin's fossa. The gland is buried deep, right adjacent to vital pelvic vasculature and musculature, so they have to find the avascular plane, often confirming the location, by sliding a closed hemostat into the potential space superior to the gland.
And once that anatomical plane is verified, the CO2 laser is used to meticulously dissect and shell out the entire chronically infected gland and its fibrotic duct.
By removing the specific, deep-seated tissue architecture that was permanently altered by the recurrent abscesses and marsupializations, you eliminate the actual hardware driving the CRPS loop.
Precisely. Because it targets the exact source of the fire without requiring a massive vaginal advancement flap, it is significantly less destructive to the overall vulvovaginal architecture.
And the clinical outcomes in Reed's study are incredibly compelling. They show a 94% success rate in reestablishing pain-free intercourse for these highly refractory patients.
Which is huge.
Yeah, because it allows them to finally utilize the biofeedback to resolve whatever lingering muscle tension remains.
Right, and I think the clinical takeaway here is paramount. A mechanical intervention to clear a glandular duct is never just a mechanical event. The structural trauma of recurrent marsupialization dictates a cascading biological response.
Absolutely.
Yeah.
Let's synthesize the timeline here for you listening. An obstructed Bartholin gland becomes an acute abscess. To drain it, surgeons perform marsupialization. If done recurrently, the physical cutting and suturing leaves a peri-orificial scar.
And if that scar isn't actively managed with a strict glass dilator protocol in the fourth postoperative week, it hardens into an inelastic white scar, creating permanent architectural strictures.
Exactly. Then, the chronic inflammation and recurrent trauma cause mast cells to dump nerve growth factor, which physically multiplies local pain nerves by a factor of 10. This hypersensitivity crashes into the spinal cord, triggering a paralyzing loop of pelvic floor muscle spasms and ischemic pain.
And, the literature strongly reinforces that chronic pelvic pain syndromes of this nature are rooted in quantifiable objective pathophysiology.
Meaning it's real.
Yes. The altered architecture, the nerve proliferation, the lactic acid buildup, these are measurable physical realities.
Which serves as a profound validation. The historical medical gaslighting of women with chronic pelvic pain, the dismissal that it is idiopathic or just psychogenic, is fundamentally dismantled by this data. We are looking at a highly complex physical rewiring of the body's peripheral and central nervous systems, initiated directly by surgical trauma.
The physical mechanisms are completely undeniable. However, examining the sources on functional pain syndromes invites us to consider a pretty fascinating intersection between the altered hardware and the patient's autonomic state.
Oh, interesting.
Yeah, functional pain is heavily mediated by the autonomic nervous system. Those are the sympathetic fight-or-flight pathways that operate below our conscious threshold.
The pathways that govern our survival responses.
Correct. The autonomic nervous system is intrinsically linked to our psychological state, to stress, anxiety, and fear. We just spent this entire deep dive establishing that physical trauma and chronic inflammation cause mast cells to synthesize nerve growth factor, which physically multiplies pain nerves. But the lingering, really provocative question is this. To what extent does the patient's psychological state during that traumatic recurrent cycle of abscesses and surgeries act as a biological fertilizer for that nerve growth?
Wow, wait, so if the nervous system is actively constructing its own architecture based on the perceived level of threat.
Yes, if a patient is locked in a state of intense autonomic distress, fear, and emotional trauma during the postoperative healing phase, is that emotional state actually amplifying the release of those inflammatory cytokines?
Are the emotional memories of recurrent pain physically contributing to the construction of the very nerve pathways that lock the chronic pain syndrome in place?
Exactly. It suggests that fully resolving these complex pain loops requires us to understand how profoundly our perception of threat dictates our physical cellular architecture.
The body doesn't just remember trauma. It physically builds monuments to it. You go in to simply clear a clogged valve, and you walk away needing to decode the entire alarm system of the house. It completely redefines what it means to heal from surgery.
It really does.
Well, that gives us all something pretty profound to mull over. Thank you for joining us in this deep dive, and we'll catch you on the next one.